Good morning, good afternoon. My name is Victor and I'm from Brazil. And today, the idea of this webinar is to share with you a new approach to enhance the peri-implant soft tissue in the anterior zone. But as an introduction for this small share of thoughts, I would like just to present myself. I'm from Brazil, as you know, as you see my flag or my name in my presentation. And sometimes when we think about Brazil, we have some stereotypes like Brazilians love carnival and soccer. But I will tell you that we have also different awards. Just for letting you know, we are ones the largest populations in the world. And also, we are the first country with more dentists in the world. 20% of the dentistry population in the world are from Brazil. So here we have a hard time. We have to work pretty hard. And also, we are the second place with scientific production in general. So we have a large production because we have a lot of people, university, and everything in Brazil. In Brazil, I live in São Paulo state and in a small city that called Indaiatuba. This city is like a farm, a country city that usually we know everyone here in the city. This is a good thing here because we can make the follow-up of our patients. So I will start this presentation sharing a little bit the follow-up of some cases, and then we will understand why sometimes we have to think outside the box and why sometimes we have to change some procedures. Um, this is a paper that I published in 2006, 13 years ago. Okay, so it's a paper about veneers preparations. So we did some veneers preparations in this patient, and in 2017, exactly 12 years after we finished the case, and 1 year before we published, we did the case. So this is the follow-up, the actual follow-up. So you can see that the patient has some problems as recessions and some wear in the natural tooth. I think this is normal, no? If you are working in a private practice, after 10 years, after some years, we start to have some problems in prosthesis. We cannot say that this will be forever, and we know all prostheses will have a weak link, and sometimes we need to guess where will be the weak link, or we need to planning to place the weak link in some place that could be predictable to redo the treatment. So in this case, we can see that we have this kind of recession, but the good news in this case that the teeth 11 and 21, I think 15 years ago, had two perforations in the middle third of the root. And in 2004, the endodontist closed the perforations with MTA, and then he blocked the perforation, and then we restore. But after 13 years, the patient come to our office for a normal maintenance, and she complained us that she felt something different in the tooth. And then we start to investigate everything, and we found some resorption in that root that had the treatment with MTA. So now it's time to go for the extraction and place one implant. So we did this case in 2016, 16 with MIS, starting use the guides and everything, and we could deliver for the patient a good solution, a guided solution with a small implant, a narrow implant, placing in the correct position, filling the gaps and everything. So the fourth thing that I learned after 18 years work in my city, that we have tried to maintain the tooth as much as possible, because things that we think 15 years ago probably nowadays are completely different. Sometimes we think that we know everything, but after 10 years everything starts to change, and things that like we think that it's perfect for that solution maybe will be a large mistake in the future. So in this case, nowadays we place a narrow implant in the correct position, and we could enhance the tissue biotype and also mimic the nature, and then we start to work with provisionals to deliver a acceptable solution for our patient. But think, we did that case in 2000, the first time in 2005, okay? This case was performed for a friend, Mario Groisman, in 2002. And he told me that he traveled around the world showing this case and this solution in 2002, 2003. And see that 12 years, what happened with the same case that one day was a cover in a magazine. Now we have a large problem. We have a large problem because in that time, probably the solution for anterior, for imminent implant in the anterior zone was a wide implant trying to fill the gap with the implant. But we know that this kind of solution we can remove nowadays in the easy way with some retrieval, place another implant and finish with acceptable solution. So these are things that we are learning with the time. There are things that probably we are changing and trying to create this appropriate clinical treatment planning. So cases like that, nowadays we perform always trying to following some rules. In the anterior zone, we try to use narrow implants. We try to guide it then, and we try to place in the correct position that we will discuss a little bit in the next few slides. Okay, so this is a little bit about my clinical experience, but also we have some follow-ups of our cases with implants. I showed in the beginning with teeth, and now this is a case that we performed in 2009 in your left side, and this is 10-year follow-up in 2019. We published this case in this book that we have in Spanish and in Italian, and a new version in English. Okay, this case you can see that number 11 have acceptable stability in the gingival level, but we can see some lack of papilla in this case. If we see in the occlusal view, this is a very important picture that we always have to check to see the real scenario, not just from the frontal picture. And we can see that we have some lack of tissue, or we had some deficiency after some years. So if we start to see the x-rays, we can see that after some years we start to have some bone loss in the distal side of the implant. And when we have this kind of bone loss, we start to ask why these things happen. And some doubts start to come for our mind. Was the reconnection that I did? Was the abutment design? And why we have this soft tissue loss? These are things that sometimes we don't know the true answer. So another case that we follow up after 10 years. Now it's a different scenario. Was the number 22, immediate loading, and you can see that we have stability after 10 years, we have some volume, but if we go to the X-ray, again we have some bone loss. And it's a different connection. The first one was a conical, this is an internal connection, but we have some kind of stability, but still having some bone loss. The first thing that we conclude, I can see in my cases, that also this is a kind of conclusion that we are having, have been learning from Linkevicius, that most important about connection, prosthesis, and everything is first you have to have tissue volume in height and in volume. Okay, so in our cases we have some bone loss, but we have acceptable outcomes even having some bone loss because we have been working with tissue augmentation since we start. Okay, but in my cases, if I start to show more follow-ups, always the follow-up is in the interface between teeth, prosthesis, implants, and tissue. That interface, the transition zone between restoration and tissue, is the zone that sometimes the patient complain because can decrease our static points. So we have to work in these transition zones in order to enhance the transition zone. Uh, I always like to share this kind of outcomes and some mistakes that I did, because when we have some mistakes and after a lot of mistakes, we can tell you that we have experience, because experience for me it's this old saying for a Brazilian for a French author, that experience is a fancy name that we give for our mistakes. So the clinical case that we will share, they are based in clinical experience and scientific support, and for me all techniques have to be reproducible. Okay, this is the first case that we did with MIS in 2015. Okay, with the first V3 that we placed, and I would like to share things that we did in 2015, 40 years ago, and also the outcome now in 2019. So this is a case that we can call that favorable situation, that the patient lose the number 12, the right lateral, and we will finish like this. But to arrive in this outcome, we have some clinical steps. So the patient was in our office, we did the treatment planning, we extract the tooth, and then we place a narrow V3, 3.3. Okay, usually we place 4 or 5 millimeters from the uh, gingival level that we want to work. Okay, so we place the implant, you can see the position, we perform one provisional with peak abutment. I will tell you that nowadays the peak abutment for us is not the first choice. Usually if you want to work on top the implant head, try to use minimal 2 millimeters height of provisional cylinder in the transmucosal area and work with the titanium provisional cylinder. So we did the provisional first and then we start to augment. Okay, our step by step is place the implant, perform the provisional restorations, check everything in the actual tissue, and then after the provisional is done, we will clean the provisional. In the meanwhile, the we will perform the bone graft and the soft tissue augmentation. This surgery was did from our partner, Paulo Fernando. So this is the final outcome, the final surgery, and this is our final tissue control in 2015. And then we start to work on top of the teeth. We did the normal protocol following Pascal Magnier and Galip Gurel rules. We did the wax-up, we placed the mock-up, and we start to work on top of the mock-up to perform veneers restorations. So we have this kind of situation. We can see that the tooth that we have more stain color, we prep a little bit more than the tooth that is in the actual natural color. And then we did the impression and we work to the lab and then we perform restorations on top the implant head. You can see that in that time, in 2015, we used 0.5 millimeters transmucosal height. And this, please don't do, okay? Nowadays, MIS has four heights of transmucosal heights and try to use at least 1.5 millimeters, okay? Um, because this will be too close of the implant head and you can have, or sure you will have, bone loss. But in that time we just had this option and we place and we finish the case like this. So you can see the final outcome is acceptable, you can see the smile, you can see the patient, but let's go to see the x-rays. When you see the x-rays, you can see that we have a little bit bone loss around the implant, and probably because we use it uh, small transmucosal height, okay, 0.5, and we know that we need to be far from the implant head. But the question probably is why in the clinical view we cannot see any recession or papilla loss because we have a lot of tissue. But imagine that the patient could have some problem in the tissue and we lose a little bit the volume and probably we will have some clinical view with recession. So we have stability now because we have a lot of tissue, but we have some bone loss. Our goal nowadays is still work with soft tissue augmentation, but also try to find a clinical protocol that can enhance us to avoid bone loss surround the implant head. So in this case, we had some follow-up with 4 years as we share. But now it's time to share the new approach for you. Okay, so I hope that you understood that we share a little bit our experience with some cases that we did, our mistakes, and some tips how to avoid this. But now it's time to introduce the new approach. This is a case that I did in 2009. Okay, we did on top tooth, the crown on top number 11. In that time, we had some fracture. We performed some anatomic post, and we performed on top this some insert crown. And the patient came to my office in 2018. Okay, last year, and complain about some tooth mobility. But when I start to perform the clinical examination, we could see that we had some fistula on top the restorations. And also after I removed the crown a bit, I could see some fracture close the gingival level. And then from the occlusal view, we can see a big or a large crack on top of the root. So the anatomic post, the fiber post, also can break some roots. If we see in the CBCT, we can see that we have bone for immediate loading. We don't have the buccal bone, but we have a lot of place to place an implant on the palatal bone. Now it's time to perform our restorative point of view. So we have to perform a pre-extraction treatment. We have to perform some protocol to maintain the tissue architecture, and then we will have to manage the tissue and also to choose the correct abutment for this clinical case. So to decide how deep should we place the implant, that it's very important. We always follow our article that we did in 2017 in KDT that called Decision Making Process for Restoring Single Implant with my friend Alvaro Blasi. And in this case, and we can see that our reference to place an implant is the number 21. But you can see that 21 has a recession. So now that it's time to decide if we will follow the actual tissue level in number 21 or we will perform something to enhance the size and length of these teeth, and maybe we can work in the CJ, maybe we can perform some root coverage and enhance the proportion at number 21 and then make place the implant. But if we want to cover the root of the number 21, the implant position have to change. So my first advice before you start a clinical case, before you place the implant, before you start to plan in the MSoft or with MSoft or with MGuide Center, try to know what will be your final reference of gingival level to place the implant. So in our case will be CJ of number 21. So you can see that from the first picture for your left side for the right picture, the tissue come down coronally a little bit because we remove a little bit the volume of the crown during the time that we had to wait for perform the surgery because the patient was with active inflammation, so we prescribed some antibiotics, and also we have to wait the clinical scenario. Also we have to wait the guides and everything to place the implant. So during 1 week we just remove the counter of the crown and you can see that tissue come down a little bit with these draws. Now you can see that we enhance a little bit before surgery. Okay, so now it's time to planning how deep we will place the implant. So we extracted and Paulo Fernando placed the implant that worked with in our team in Brazil. So he placed the implant 5 or 4 millimeters, between 5 and 4 millimeters from the future changeable level that we want to work. And our reference is the CJ of the number 21. After he placed the implant, we start to work with the new approach that is the connect abutment from MIS. Connect abutment is an intermediate abutment between the T-base and the implant head. This connect abutment may could be more easy to understand if we compare him as a multi-unit. But you know, multi-unit from the name is for multi-units. This could be a multi-unit for single unit restoration because this is for screw retained prostheses, for cemented retained prostheses, and also with index that you can work for single unit. But this piece, this small piece, has a lot of advantage for another piece that works maybe similar for this because this is one piece, no screw between this piece and the implant head. It's a one piece that has a real cone Morse activity. So no infiltration, no movements. And also this piece has a lot of heights that you can place the connection of your provisional ortho base if you want in the tissue level close to the bone in the middle of the tissue, so you can play and place wherever you want. You can work as a soft tissue level abutment or maybe medium level of uh, implant abutment. So try to see in these designs that MIS offer for you, that you can find in the website. You can see that we have the implant head here, and also we have the connector abutment. You can see that the connector abutment has changeable heights as 1.5, 2, 3, or 4. And also the connector abutment you can place in the same moment of the surgery or in the second stage. The connector abutment you can place with a torque between 30 newtons, and also after you place the 30 newtons torque you will perform a provisional restorations, or you can place also a healing abutment on top this connect abutment. This will be to place your interface, the restorative interface, far from the bone, and probably you will enhance all things surround your implant. So try to see in this graph that usually we place the implant 4 millimeters from the future gingival level. If we place 4 or 5 millimeters, probably we will be 2 or 1 millimeters inside the bone, okay, subcrustal. And then if we start to reconnect our provisional cylinder, probably we will damage everything surround the bone. But if we place the implant subcrustal and we place the intermediate connect abutment, we can place a little bit far our reconnection, and with advantage that we can manage a bit the tissue if we want, and also for the patient we can protect the bone. Okay, so this is idea. But remember, when we place an implant, we always see that contours and everything, but the contours has a lot of variables as diameter, position, and how deep we place the implant. Sometimes if we place the implant in the correct position, we'll have appropriate contour. But if we place the implant a little bit buccally, we have problems. If we place a large implant, also we will have problems with the contours. Okay, so your position, your diameter, and how deep you place the implant are variables for your final design of your restorations. So when you perform your restorations, sometimes you can work on top the head of the implant and you have a design with concavity and then convexity. But if you place the connect abutment, probably the concavity will be in the connect and your crown will start with convexity. So this you have to change your mindset. We use the connect, we perform the restorations, and you can see that after 6 months we have acceptable outcome. Okay, if we compare, now we are in the favorable situation. Now it's time to take an impression. For to take an impression with the connect abutment, we can go in the traditional situation with a coping tray abutment that we will place on top the connect, and we can take an impression. Or also we can go with a scan body and scan this. Okay, and both are strategies that are working pretty well with MIS. We started using the tie base and the connect in the prototypes, so we found some mistakes that MIS correct everything for after launch. We are in the comfort zone. But in the beginning, with the Thai base, we just had three positions to position the Thai base. Now we have more than eight positions that we can choose to place the Thai base in the correct way to perform the final restorations. And also the Thai base that we have nowadays is for normal position, and also they will launch a Thai base with ease solution that we can change a little bit the angle between 20 degrees, and we can change a cemented restoration for the screw retain situation. This will be pretty nice. So what we have for the connect implant, we have the connect abutment with different size. We have the cover for this connect abutment, normal comping tray, close or open protocol that you work. We have the analog for normal stone model. We have the analog for printed model. Oh, sorry, for printed model. We have the scan body, and we have the metal cylinder abutment, the temporary cylinder abutment, and also the final T-base abutment that you can see in this drawing, the last one, that nowadays we have a ring between the tie base and the connect, or between the tie base. We have a ring in the tie base that will be between the zirconia restorations and the implant head that will enhance the fit of this tie base. So in our case, so now in the lab we start to enhance the contour of the abutment, and then we went to the mouth, we changed restorations, we place the abutment, we take an impression, and in the lab we start with digital procedures. We take a normal impression, and in the lab we work digitally. So the first step to work in the lab, after we took the impression, the technician start to customize the zirconia. So he customized the zirconia first with color and then shape. And after he balanced the color and shape, the abutment with the veneer preparation that he had in the other side, he pressed for restorations. So this is our final result of the lab made for Cristiano Soares from Brazil. So you can see in details that we have the connect abutment, we have the tie base, and then we have the zirconia solution. This zirconia solution is raw inside the tissue, and in the gingival level we can have color, okay, and then four restorations on top of this. So remember, tie base is a solution for the prosthesis parts. So these are different views. And remember also, when you work with implants, we have an emergence profile. And in emergence profile, we have the angle of emergence profile. Usually, when we work with implant, our angle of the emergence profile will be with volume, but when you place the prosthesis in the tissue, will be with the correct emergence profile. So these are the training, and for the final bond restorations, we use a rubber done and bonded all restorations. And this is a little bit the follow-up after 9 months, and you can see that we have a lot of tissue that probably will enhance our outcome, and also our reconnection was a little bit far from the bone, so probably we will have less bone loss comparing the case that we did in the past. Okay, this is the CBCT for our final case, and this is the image comparing our situation. So the conclusion that we are having nowadays using this kind of solution, that this in the anterior zone will help you to have less bone loss. So if you want to use, try to think like this way. If you place the implant inside the bone, okay, the implant head inside the bone, you didn't use the bone level approach. If you place subcrystal, if you start to reconnect, you have some bone loss. If you want to avoid this bone loss, you have to use minimal a connect that will place your implant reconnection on top of the bone. Okay, if you place 2 millimeters deep subcrystal, you have to use at least 3 millimeters of the connect because your reconnection will be on top of the bone. Okay, but you can use more with more length if you want to work like tissue level. It's your decision, but work inside the bone with reconnections, we know the problems. So nowadays it's your choice to change this approach to avoid bone loss. And if you use the full package, place guided in the correct position, if you use the connector abutment, if you augment in the correct situation, probably in the future you have better outcomes that I share with you, that the ones that I share with you. So this is my conclusion about the new approach we are using. Since the prototypes, we can say 1.5 year, and we are having a predictable outcomes and acceptable outcomes. Thanks so much, and I'm open for questions. Uh, I think that we have a questions for Ed Harris. He told me, "Hi doctor, do you use connective tissue graft in your cases?" Yes, and the answer is always. I work with the Implant Patio group from Brazil. Usually the Paulo Fernando is the surgeon that share the case with us, and he plays the connective tissue graft 100 in the cases. Lisa, Lisa, the orthodont concerns if you can place movement on top the connect. If the question is about this, MIS did some uh, research with connect and try to see the strength of the connect, and I can tell you that you the fracture torque was 160 newtons and the fatigue test was 210 newtons. So if you not make strength force more than 210 newtons, you can place ortho on top the connect abutment. I don't know if this was the question. Could be beneficial preserve the emergence profile of natural posterior teeth if am I going to put an implant after. So you will first probably extract it, then augment, and then you will place the implant. I think if you will do this, you can try to, with a provisional, maintain the emergence profile of the natural posterior teeth. But this will cost a provisional that you have to hold in the tooth, probably in the adjacent one. So maybe sometimes you have to prep or to bond, and will be a lot of work. If the patient just lose one tooth, I will augment and close, and after this, you can you can perform a new emergence profile. But nowadays, my friend, if you have the DICOM files before surgery, you can connect to MIS, and then after you place the implant, MIS can come back for the tooth contour in the first DICOM file and perform for you a customized healing abutment following the natural contour of the tooth that you extracted. Okay? Haley, thank you for your um, message. Okay, Elizabeth, thank you. Hope to see you soon. You are a great friend. Always help me. Okay, if we are not have more questions, we will finish. And thank you, Jeff. So I hope that we could share some knowledge with you, some tips of your clinical experience, some tips about the Connect. That's a great choice to start using in your static cases. And soon MIS will launch the the connect for the posterior area that will be very nice. And just a final conclusion, some people are asking me sometimes why not to use a tissue level implant instead of using the connect. But if you see the design of the connect and the design of the tissue level implant are completely different. Okay, so try to check this. And also another companies, they have some similar components, but the screw are not one piece. So probably you have some movements and you can have some problems. Okay, so thank you for everyone. Thank you, Dental Tribune Stud Club for this opportunity. Thank you, MIS, for support us, and hope to see you soon. Bye bye.